Hi, welcome everybody. It's Friday, the 20th of February. We are going to do sort of a markup and possible vote, and we're also going to hear from Helen Robinson from Vermont NEA, just to make sure that everybody's in alignment on this bill. So, Helen, did you want to come on up and just speak to this bill and if there's any concerns or?
Good morning. Good to see you all. Thanks for being here for the record, Colin Robinson, Vermont NEA. And just want to say thank you for quick work on H 558. Wanted to let you know that we checked in with folks who are engaged in this type of work to make sure that schools are receiving Medicaid funding in the most effective, efficient ways to meet the needs of students and to provide supports and services to as many students as possible. And we connected, as I mentioned, with some of our national partners, both in the nonprofit as well as policy experts at our national. And thumbs up on the bill. They said it made a lot of sense, that it is best practice, that it's being developed across states in other parts of our country, and that it is a positive step forward to making sure that those resources are maximized for school districts to support students and particularly to access their education.
Great. Services are already providing.
Yeah.
Ensuring that we're maximizing the money.
Yeah. Oh, exactly.
Yes.
And my understanding is that this has the potential to bring in some resources that might not already be, school districts might not already be compensated for. And that is a benefit to taxpayers as well as benefit to the students that need to access those supports. Yeah.
Okay, I'd just like to go from square one here. Okay, so what we're talking about is the State Medicaid Agency, Human Services. They're going to be responsible for determining and maintaining the program. Then they turn the responsibilities over to the Agency of Education.
I believe that they are responsible for the funding of the program,
Yes.
and then they turn over the responsibility for actually
Implementing goes to the school.
to the Agency of Education,
Yeah.
who's best in a position of implementing policies rather than
Okay,
DEVA or AHS, which is best at
so let me,
paying for services.
then let me follow the money. What's the steps where the money goes? You're given a service, it's going to cost to implement and to do these things. All right, so who bills Medicaid?
Why don't we?
I was going to say
wait
legislature.
until Jen did, unless you,
This is legislation already received from actually last week. I can do my best.
could you do?
Actually,
I would defer to somebody else to
Okay.
address that
No,
question,
yeah.
you know, the
I'm just trying to
specific
get all the
machinations.
implements together, you
Yeah.
know.
Yep.
I'm sure it's fine. Might have to explain this next week.
Yeah, no, fair enough. I would say from our perspective, the headline is that right now schools are already receiving Medicaid money, and this
Mhm.
creates a more efficient way to ensure that the maximum allowable resources are getting to schools and students that need those resources. And by creating those efficiencies, that means students are able to receive that support they need, and potentially that means it's going to have a positive impact for taxpayers as well, right?
Sure.
So, but as it relates to specific A to B to Z, I would defer to others. Yeah.
Just seems complicated.
You know, a lot of things are pretty complicated, but I
Okay.
thoroughly appreciate your desire to understand that complexity because it is important. Details do matter.
Thank you.
Thank you, Colin.
Thank you, Madam Chair.
Ava. short notice.
Absolutely.
Appreciate it.
Yeah. Jen, do you want to come on up just so we can? If anyone else has questions, we'll put the language up. We have it on the schedule for markup, but I don't believe we're actually marking anything, just set. So this is what we were brought through the other day.
Hey, good morning, Jen Kirby from the Office of Legislative Counsel. I will start by putting the bill language up, but then I may use some of Ashley's presentation from last week.
Yeah, it's last Friday.
Great.
So I'm looking at slide 6 and that.
Right. Yep.
Slide 5 and 6 kind of explains.
Yeah, so I will do that, but first let's just look sort of generally, I think from the statement of purpose of the bill, this is transferring sole authority over Medicaid school-based services over the program to the Agency of Human Services. Right now, it's split between Agency of Human Services and Agency of Education, which may not be the most administratively streamlined way to do that. And I think the Agency of Education folks don't live in the Medicaid program administration world the way the Agency of Human Services does. And then it also makes some changes to the amounts of the reimbursement that go to the agency and to program administration and are available to go back into the general fund or education fund, sorry. So now let me, if I can find it. Just pull it up, let's see. Actually, there we go. All right. So now I'm going to put up, this is not my presentation. This is Ashley Berliner's presentation from last week. But I think slide 5 is helpful in explaining what they were going for. So in this bill, it establishes, it sort of closes out an existing special fund and creates a new one that the money would for AHS would go into to reimburse schools from the federal Medicaid payment. So right now, as I understand it, school pays to provide the services and then the reimbursement comes in from the federal government through for a portion of that through the billing federal Medicaid. And so this is, and some of that is administered through the Agency of Education. So all of that part of dealing with the federal government and getting the money would be at the Agency of Human Services with a special fund for that money to go into. It bill establishes the Agency of Human Services and through them, the Department of Vermont Health Access as the administrator of the Medicaid school-based services. But the services themselves are still being delivered in the schools by school personnel. It gives rulemaking authority to the Agency of Human Services, and it requires the agency to support schools by funding and providing the tools that are needed for program compliance. And the piece that stays with Agency of Education is authorizing the agency to define how schools can use the federal payments from the Agency of Human Services for the Medicaid services that are delivered. They're calling those reinvestment dollars, and giving the Agency of Education rulemaking authority to set requirements for how schools are allowed to spend those reinvestment dollars. And there's a bit of funding changes that she had gone over. So in the current allocation, 50% of what comes back from the federal government for these services is available to the schools. Up to 30% goes for state administration, and then 20% and whatever is not spent of that 30% goes into the education fund. And then there's separate piece I'm not going to talk about, it's not really relevant to this bill. And then what they're proposing is that 55% instead of 50% goes to the schools. And then the administration number changes from up to 30% to up to 25%. And then still that 20% and unspent administrative dollars go into the education.
And just a reminder, this bill to probably immediately go to Ways and Means, who I am certain will be asking all the questions around the numbers.
When you look at the sponsors, we've got
All of them.
means.
Right. So, I mean, I think as I understand it, sort of the biggest takeaway is that it stops the administration from being split between the Agency of Human Services and the Agency of Education. Agency of Human Services is the single state agency for Medicaid, federal Medicaid purposes. And so they would be doing all of the administration stuff and also changing a bit, increasing by 5% the amount of the federal reimbursement that is available to the schools.
And then there's a whole EMR part.
Great. Any other questions? Do you want to go, do you want to put the language back up? Just,
I can if you'd like. Find it again.
go ahead, Brian.
It's not really a question, it's just the sense I'm getting that is that legislative council has worked out the language to make sure that it's achieving the intent. So like, I don't see any reason to like that I would need to like change what it says. Like, I'm reading it, it's pretty like technical or something, you know, it's a very technical bill, but like, it really sounds like it's just about improving the way that we can fund these services,
Yeah.
right? So,
Taking advantage of federal dollars.
yeah,
Right, although it's not changing anything about federal dollars, it's just, I think, ensuring more streamlined compliance with federal requirements. So if we want to look at language, it specifies legislative intent that the state maximize its receipt of federal reimbursement for medically related services provided to students who are eligible for Medicaid, and that our school-based medical assistance program comply with all federal Medicaid requirements. And as the state Medicaid agency, the Agency of Human Services will have sole responsibility for determining and maintaining program compliance. Then it specifies what the Agency of Education is responsible for. That's for coordinating the school-based medical assistance program with statewide education policy and objectives, and for communicating with supervisory unions, and that may specify the use of program funds received by state education agencies in accordance with provision of existing law. And so this is existing law that I think we amend in here, but saying how schools can use the reimbursement dollars that come back in.
Val?
Not to dive into a different rabbit hole, when, with the school, possible changes going on, would supervisory union ever be a problem?
I think we will, if there are changes, yes, we will need to go through all of the statutes and make sure that they are consistent with whatever the terminology is. So yes, and you know, we'll be. Okay. Fair question.
Leslie?
I actually had the same question, Val. So, but we currently have more than supervisory unions, even in the current world, right? There are some supervisory districts.
So this is where I'm gonna phone a friend on the side if you want to talk about the.
Or does this cover everybody, no matter what?
I think there's different ways that things are laid out in existing statute that this is reflecting as far as communication with supervisory unions and program funds received by state education agencies. But I prefer to call.
Yeah, Colin Robinson, Ron NEA. So your colleagues down in House Education had this very similar conversation with Legislative Council yesterday.
Different legislative council.
That's St. James, who does education, and they were talking about the BOCES enabling legislation. And in that legislation, it only uses the term SU. And it was confusing the committee and Legislative Council. I don't want to speak for her, but what I heard reflected in that conversation is under statute is sort of an all-encompassing term for the various types of school government structures that exist in statute right now.
Thank you.
Yes.
Thank you, Tom.
Jen.
Oh, I'm sorry, Alan. I'm sorry to
Oh, that's all right.
interrupt. I had forgotten that. Alan,
I don't,
you're all set. Okay, go ahead, Tara. Sorry.
I'm trying to get what you're doing, you got up there. I can't get it.
I think it's not
I can't see that.
posted under today.
I just.
Okay.
Sorry.
No, that's okay. So if you refresh, you may be able to find, it's just H 558. Otherwise, you can look up H 558 as introduced, and that's all on. Right, want me to keep going through it or?
Just, we went through this bill the other day, hasn't changed.
It's not.
Are there any other questions about this bill? Again, this bill will make several stops along the way.
No.
I just trying to distinguish between policy and money. So the only part that's our job is the beginning part. The rest of it's kind of money because it's the reimbursement fund. So it's really just transferring the authority. That's
Transferring
all
the
we're talking
authority
about.
to.
Yeah,
Agencies, right, AHS.
yeah. So that's all we're talking about.
All we're really talking about.
Could you refresh us on section 2?
Sure.
Section 2 is the special fund.
Yes.
Yes, so that there is, I believe there is a special fund in existence. Yes, there is a special fund in existence right now in Title 16. That is the education title. And so this is creating kind of, the bill is repealing that and creating kind of an analogous
So we're
special
not going
fund.
to, this is good.
Right, this is
Okay,
gonna,
okay.
this
Yeah.
replaces, because if
Okay.
you look at section 3, right, yes, it's starting on page 5. It strikes the whole Medicaid
Yeah,
special reimbursement special
okay.
fund is established in the agency of education.
Okay.
And it does this, it has this section 2 special fund instead.
Good question. I don't know if you can answer it or not, but how is by combining this, is it increasing the federal reimbursement?
I don't think it's increasing the federal reimbursement. It is expressing legislative intent that we maximize our receipt of federal reimbursement. And I think the idea there is that AHS, as the single state agency for Medicaid program administration, is best positioned to make sure that their administration is in compliance with federal requirements, which is what's necessary for us to ensure federal financial participation.
So just playing by the rules is.
Yeah, I think so. I don't think it's going to change anything unless AHS may have a better sense for how to document services provided that would allow us to more closely track reimbursements with services that are being delivered. But I don't know if that
makes
is
sense.
kind of speculation, but I think, yes, I think they're the experts in the Medicaid program administration area. So they're best positioned to administer.
Okay. Any other questions? If none, I would entertain.
Move. I'll move.
Second. What are you
At
moving?
558. That we pass it out. The way it's written.
As introduced.
As introduced.
Can I just ask a question? So by passing this, we're going to send it on to Ways and Means?
Well, the clerk of the house will send it.
Okay,
I believe this bill's gonna have to go to Ways and Means, probably education,
Okay,
probably
that's what I'm asking.
appropriations.
So,
It's got a lot of places to go.
okay,
But we're sending it with our approval. We're not just
Right.
saying,
Yes.
we're not just punting it. So this is us
Yes.
giving us our blessing
Yes.
and sending it off to the next stop.
Reporting it favorably.
yep.
Yes.
Yes.
Just- I bless it.
Yeah.
So.
Okay. The clerk will call the roll.
You have a reporter?
Brian Chino,
Yes.
Be Critchful,
Yes.
Anita Mar,
Yes,
Leslie Goldman,
Yes.
Lori Houghton. Aaron Wonders,
Yes.
Deborah Powers. Yes. Valerie Taylor. Daisy Rebecca.
Yes.
Matthew James.
Matthew James, wow. Where?
All right, we're in the middle of a roll call.
Melissa Black.
Yes,
So it's 10-01.
great. Thank you, and Daisy, will be the reporter of this bill. Great. Thanks, everyone. We all have this on our desk. Please print out? Yes.
Can we put it on our, somewhere in there in this week?
Already, it's there.
Oh, that's good. A
Yeah.
different date from the 18th. I was just, okay, thank you.
Let's move on. So we are, we're moving on to a new bill. And this was introduced by Representative Michelle Boslin. So we're gonna have Michelle come up first and just sort of, tell us, give us an introduction of why she introduced the bill, and then I believe it's a short form, but we'll have Jen walk us through, I don't know, 2 sentences. But I thought it would be best if Michelle just introduced it first to us. Oh, there's like 5 sentences.
I have a few more than 5 that I'm going to share with you.
Welcome, Representative Boslin.
Thank you. So for the record, I'm Representative Michelle Boslin from the Wyndham 3 District. I'd like to thank the chair and all of you on the committee for taking time to hear about this issue of medication from specialty pharmacies being allowed in all inpatient settings in Vermont for individuals. To explain how I came to introduce this bill, I'm going to tell you a little bit about my own health situation. I was diagnosed with a rare form of lung cancer last November. Neither surgical treatment nor radiation are possible in my case. The only treatment to reduce the cancer in my body and keep it from metastasizing is a targeted therapy, which comes in the form of a prescription from a specialty pharmacy. I need to take these 3 pills every day, and I need to reorder these 2 weeks in advance. There are many medications that come from specialty pharmacies that hospitals and nursing facilities don't stock. There are over 7,000 rare diseases, and not all of them have specialty prescriptions, but many of them do. For those that do, being able to take a prescription can literally determine life or death if someone finds themselves in an inpatient setting. When I asked Ledge Counsel about this issue, I was told something like, there is nothing in statute that requires hospitals to let you take your own medicine. I learned last night there was a survey, and it turns out all Vermont hospitals actually do already have a means to allow people to take their own drugs in these types of situations. But long-term nursing and rehabilitation facilities are also inpatient options where someone like me might have an inpatient stay. The way I learned about this type of situation was from a person who shares my diagnosis, who was preparing for a knee replacement. He wasn't in Vermont, but he was planning to go into a nursing facility for a multi-week recovery period after his surgery, and he was told he could not take his own medicine. I don't know the policy of long-term stay places here in Vermont, but it seems to me it would be wise to ensure that somebody in my situation would be able to take their medication, whatever kind of inpatient setting they're going to land in. There's no such thing as a simple bill, but compared to most, this one is simple. So if you can put into statute, people with rare diseases have a right to take their own medicine in inpatient settings, that would ensure that no hospital is going to change their policy to make it complicated, and that in inpatient settings for short-term or long-term stays, people would be able to take the medication that they might have to order through different means than whatever would normally stock the pharmacy in the inpatient setting. So H 736 would ensure that Vermont hospitals will continue to allow people to take their own drugs, and any future situations where inpatient stays, it would be continued to be allowed as well. So thank you for considering this bill, and I'm happy to answer any questions.
Anyone have any questions?
Oh, I might.
Okay.
I agree with it.
Okay, yeah,
And, but when you say to bring your own medicine
Yeah.
to a nursing home setting or
Yeah.
whatever,
yeah,
there's still got to be some kind of a responsibility on that agency to make sure you don't overtake or undertake or not take, or
right,
So-
and, right.
how's that going to be addressed in this?
Well, I mean, currently, as I understand it, all hospitals actually have told someone who's in this room that, that they do allow people in these settings to take their own medicine. I don't know exactly what that means. I wouldn't be surprised if there is a thorough process where you have to submit your specialty medication, and then the nurses would bring it into you along with the more routine medications that you would be taking. But honestly, I don't know the answer. I think maybe what the policy would be each long-term inpatient setting needs to come up with a policy so that when this happens, because I'm not the only person with a rare disease in Vermont, there are thousands of us. They'll be ready and they can have a procedure that they can follow through with.
So would there be any liability on the hospitals or doctors or nursing homes?
You know what? I don't know the answer to that, but somebody
Well,
with
yeah,
more legal
that's the
background
thing,
than me would.
Because not every situation is going to be the same.
True. But then the other side would be if you have an adverse reaction because you're not allowed to take your ongoing medicine, that would be a consequence too.
But they've got to know what medicine you've taken.
True. I mean, this isn't about secretly taking your own medicine.
No, but
Right.
everybody's got to be on the same page.
I agree.
Can I comment on that?
Yeah, and I think,
I just want to say, reassure, there are medication lists that this medicine will be on so that everyone taking care of that person will be aware.
and I think we'll ask Devin when she testifies. I think she's probably best.
Yeah.
Yeah, that I am not, I am not an expert in any way in any of these issues. This is all very new for me. But when I heard somebody in a group of people who have my condition said, this is a big problem, you should all talk to your legislators. And I thought, okay, all right, I've got something to add of my list of things to do.
Brian and Daisy, but I wanted to ask you really quickly, just from a practical standpoint, you had this drafted as a short form.
Yep.
Have you worked with either legislative council or do you have language that is already being worked on that?
There is not further language at this point.
Okay.
I mean, if you needed me to find some from other states, I probably could, but Leg Council might be able.
I just didn't know if you were
Yeah,
already
no,
working.
I haven't because I wasn't sure if,
Everybody a little time.
right, I know. I wasn't, yeah.
Right.
One of my questions was gonna be if you knew of any other states that had taken action like this. And then the second question, you might not be able to answer, but I'll ask it and then Leg Council or someone could. I worked in situations where when we're referring somebody to inpatient, they say, tell the patient to bring their drugs. So I'm confused, like why we need to do this. I'm not saying we don't, but like it's confusing that for your case, these are legitimate pharmaceuticals approved by the FDA that you're being prescribed by a provider.
Yeah.
Why would that not be allowed if we're telling a patient to bring their Seroquel to the hospital with them when they go in or that kind of thing, I don't understand why they're not letting all patients do that already. And you may not know the answer to that. Maybe the hospitals do.
Well, let's ask.
Yeah.
Yeah, I don't know the answer. I don't know the answer to
Yeah.
that. But I just know that in some instances, people have had difficulty
Yeah.
taking their own medication. And it feels like a good thing to solidify so that this doesn't have to be an issue.
I agree.
And let's not forget that we always tend to think of inpatient as being inpatient hospital, but there are many, many steps along our continuum of care where people actually are technically inpatient residing long-term skilled nursing facilities. And so
Partial hospitalization be considered inpatient when you're staying overnight?
I'm not sure, but like, I can say that, I was hospitalized last year for a different reason. And all the medicine that I got, like doxycycline, all the medicine that I got came from the hospital. They stocked that in their hospital pharmacy. But specialty drugs aren't stocked in a specialty pharmacy, and they don't even have access to order those medications. So you kind of have to bring your own in those cases.
Okay, thank you.
All right.
Thanks. Oh, I'm so sorry.
That's okay. I don't have a question, but I just wanted to say thank you so much for your advocacy in this and humanizing it for us. I think it's really important that we talk to people that understand and help us understand the importance of it. And I'm glad that you're healthy and here.
Well, thank you. And thanks, everybody.
Again, for the record, Jen Carvey from the Office of Legislative Counsel. I will put up page 736. You've heard this is a short form bill. And for those who are new to short form bills, a short form bill is the whole beginning of a regular bill with who introduced it. But the subject are a statement of purpose of the bill as introduced, which is really the Legislative Counsel plain language summary and the title of the bill. And then that's it. It says text omitted in short form bill. So there isn't the actual legislative language to implement the changes that the bill proposes. So in this case, the statement of purpose of the bill as introduced is kind of what the bill would do if it had been drafted as a standard form bill. And so it says the bill proposes, although it doesn't actually, to make legislative findings regarding the lack of stock of medications for rare diseases in many inpatient healthcare facilities, and the difficulties that those facilities may encounter in procuring needed medications in a timely manner when caring for patients who enter the facility while on a treatment regimen for a rare disease. And the bill would require facilities to allow patients who are on an inpatient status to continue to take all medically necessary medications prescribed for them by a licensed healthcare provider, even if the facility does not typically dispense or administer one or more of the medications, in order to facilitate medication adherence and continuity of patient care across settings. And that is the whole language.
That's the bill.
And then the other piece I just wanted to flag in case it's helpful is, again, about short forms, and that is just the House rule on short forms, which says, so this is for orientation purposes, this is in Rule 44, and Rule 44B says, short forms shall be drafted in standard form by my office only if requested by a majority vote of the committee to which the bill has been referred. And then it goes on to say that a request by a committee to have a short form bill drafted in standard form may be for any reason that the committee deems appropriate and shall not in itself indicate an approval of the bill or an intention to act favorably on it. And then there is a slightly different process about how it goes on notice as well.
We would have to vote on whether or not we would like a standard bill drafted.
And then we would do it like a strike all amendment. It's what it looks like.
And then, but that in no bearing is a vote of passing the bill.
Exactly.
So,
I'm going to go Leslie, and then looks like you're pondering, Alan.
I just want that explained.
I'm just wondering where in the process, what we, I could make a motion to change it to a standard form. You want to do it after we hear all the testimony?
I think let's hear it let's get a little more testimony.
Yeah.
Go ahead.
Okay, no,
Oh,
no, I forgot my thoughts, so go ahead. Are you
pondering too long? Yes.
I pondered too long, yeah.
I have a question that might get you thinking, because it's a question that I could see you asking, which is when we initiate a long form request, do you know what the additional expense is to the state?
I don't know that there's a specific expense to the state. Basically, you're asking me to draft a bill.
Because I was told by another legislator that every time Council writes a bill, it costs $1,000, which I find hard to believe.
Well, I'm not getting $1,000. I'll tell you that.
Is Jen now getting paid?
So- Their claim was that they were using this in the context of like me introducing a lot of bills, saying that it cost the taxpayers $1,000 every time or something because of all the labor involved. And I'm like, but I write my bills usually and give it to them. So they're not doing all the research. And even if they are, like, how do we, so I guess what I'm getting at is I support this regardless, but I am curious when we initiate a bill request like this, what it costs, and maybe Nolan could tell us. I don't know.
So I don't believe, I don't believe there is a specific quantifiable cost associated with requesting or having a bill drafted.
Oh, thank you.
It's,
Putting that out there.
I mean, there's the social cost to your family and friends.
there's, you know, burnout and demands and so there's nothing, but, that we just ask, you know, we ask members to be mindful of how many bills you're requesting generally, because all of them do require, you know, us to do a lot of work. But that's also the job.
Just a comment, if you took all the salaries of all ledge council and their yearly salaries, if you went by 800 bills for 900.
Well, we draft more than that. So it's over
So there-
1,000.
You know, but indirectly.
But then technically, the more you ask, the better deal you're getting because you're getting more out of it for the same price.
Okay, so then you lose that council and you've got new.
I agree with you. Yeah, it's not costing us more.
Value much more than just drafting bills as the council is sitting in front of us having to listen to this. Go ahead, Dupper.
Is there any other questions on this bill? That's my,
Should we move on? Do we have any other questions for Jen? Or should we move on to our next witnesses?
I'd love to hear from the witnesses.
I love it.
Just because.
Thanks, go ahead. Go ahead. Well,
I don't know where I'm on the agenda, but I'm gonna claim it.
because I'm sure you got to get somewhere too.
Thank you very much.
Don't, Devin.
Thank you very much, Representative Van Donahue. And just wanted to share why my eyes lit up when I saw this bill had been introduced. And all due deference to future testimony, it's not an issue of, you know, what are hospitals doing or not doing now, or what state or how many years ago, but just a real life, what can happen when this happens. My dad had myasthenia gravis. It qualifies as a rare disease, requires very specialized medication to keep it. It can still be very unstable, but to try to keep it stable. And it results in usually automatic, it's an autoimmune disorder, results in muscles failing. Eyelids are really typical. The neck is typical, can affect breathing, number of other things. He was on a trip with my mom, fell and broke his hip, had to go to the hospital. My mom had his critical drugs with him, said he's got to stay on these. And they said, no, got to be hospital pharmacy. And of course, the hospital pharmacy didn't have these drugs. And so she was, you know, anxious, had the drugs. I happened to be there at the time when his breathing failed. I watched, they called the code blue. The crash carts, the get out of the room, we need to resuscitate him. And it was a direct effect of not having the drugs that were keeping him stable. After that happened, they decided to allow him to have the drugs that my mother brought until they could get them. But that's the real life of when that situation exists. That was a really, really scary thing for my mom and there to see. He stopped breathing. He had to be resuscitated for this reason and for what this bill is trying to address. So.
Thank you.
Thanks, Anne, for sharing. All right. A hospital.
Health system.
It's like hospitals, maybe.
Actually,
I was thinking about this in terms of.
yeah. Devin Green, Vermont Association of Hospitals and Health Systems. I am currently really regretting I had a pharmacy person trying to set up a pharmacy person available for today and it didn't work out. But so if you have detailed questions, perhaps we can have a time when that person can come in. But I just wanted to give a high level overview on this bill. Again, it would be great to see drafted language, but based off of the short form, the first piece I would say is I don't think we need to do a study about whether or not hospitals have specialty drugs in them because the majority do not have specialty drugs available. And so I think if we're looking to establish that, consider it established. But in terms of bringing in specialty drugs from home, bringing in medications from home, the hospitals, I reached out to the hospitals a couple of times, and the majority of them said that they all allow this. And there's actually a piece in the pharmacy board's rules that anticipates this and just says that drugs brought into the institution by patients, it must not be administered unless it can be identified and the quality of the drug assured. And our hospitals have systems set up for doing this. I did not hear from all of the hospitals. I may have worded it. It was basically like, do you prohibit people from doing this? And I'm guessing there were some hospitals that allow people to do it and felt like they didn't need to respond to me. I can reach out directly just to make sure all of our hospitals do it. But my understanding is that this is not an issue at Vermont's hospitals.
But we're not sure
just
about other, yeah.
Yeah, and for that, I would just say, I think I disagree with the definition of inpatient. I would say for skilled nursing facilities, and other facilities, I think there is a clear definition of inpatient versus outpatient, and that skilled nursing facilities and rehab facilities and other facilities are typically considered residents of those places. So you would want to look at how inpatient works there. And then I think also you'd want to talk to those facilities because I believe they have some pretty complicated federal regulations that they need to follow.
If we decide to turn this into a standard form, then we'll definitely have more people in. Go ahead.
When these people bring in their own drug,
Mhm.
do they relinquish ownership to the hospital?
Well, like the pharmacy
They
board
don't
rules,
keep it by their bedside.
I don't believe so. I believe the hospital needs to check
Mhm.
the drug and the prescription and assure its quality. And then it's possible that the hospital dispenses the drug. I can go back and
Well,
ask the,
you know, I'm sure we're okay with it.
they definitely need to keep track of
That's
what
right.
is
Yeah,
taken.
That's the
Yes,
that's the key.
yes.
Oh, I guess I don't have a question for that. It's like-
Okay.
Oh, I'm sorry, Brian.
It's okay. I just want to make sure I heard you correctly. There's two sentences in the statement of purpose.
Mhm.
You're saying the first sentence is unnecessary. The
Correct.
second sentence bears further testimony and exploration.
Correct.
Okay, thanks.
All right, thank you all.
Okay, well, I think we're done for the morning. Go ahead, Leslie.
I'd like to make a motion that we turn 736 into a standard form bill, committee bill.
Is that a
Well,
question or
wait, no,
a seconding?
wait, I'm waiting to get the second and then I'll
Oh,
make a statement.
okay.
I'll second it.
Okay. Do you want to do it in the form that it's in now with everything that's in there?
No, I want Ledge Council to review it and see what is appropriate. I mean, we'll take testimony and it needs to be turned into a standard form bill and then we'll look at it and.
Yeah, I just don't think the first part is
Yes.
necessary.
So what kind of direction, what would be the language of direction? Yeah,
Brian,
Yeah, I would support this motion if we didn't act on the first sentence and we took the second sentence and used that as a starting point. I have more to say about that, but I don't know if this is the time to give you more feedback about what might be good or not,
Well, I
but.
think the first sentence should be reiterated. No, it may be that it's already standard of practice, so we could say that.
But ask for an inventory to be, a study to be made. It's just to make findings. Oh, I see. You could just make findings.
Same thing.
Okay, all right. So you could put so if Ledge Council is the one putting the findings in, that's fine. What I wouldn't approve is a study on what the hospitals have. That's what
Again, you need to be reminded.
yeah,
Needs to be what? I'm sorry, I didn't hear.
I would recommend that if we'd like to turn it into a standard form, we would, like, first of all, either distinguishing or determination around inpatient status versus like a residential status. And that we would eliminate the first sentence for legislative findings regarding the lack of stock, because they've just said we don't have it.
We know we
It's out of
don't,
stock.
we know we don't have it.
We know we don't have it. So we don't need that. So would that be, yes, go ahead.
Do we really need a whole bill for this? I mean, it seems like a very simple thing.
Until it's not.
Yeah, my fear is it seems like one simple sentence that should belong somewhere in statute or in a provider manual. Penny's laughing at me.
Oh,
But my fear, I'll finish that thought.
I'm sorry.
Is that this is gonna be something that we need to hear from every facility about, and it's gonna take a lot of time in our last 3 weeks before crossover. And we've got AI coming at us, we've got school mental health coming at us, and we've got to wrap up the 585, 583. I'm concerned about it being a time issue, but that's why I'm questioning, is there a way we can make this a simple tuck-in somewhere?
That's
Because
right.
absolutely support the need for it, recognize the need for it, and want to do it, but do it right.
Well, may I?
Yes, although I'm not sure I can think of anywhere that this could be tucked in.
The miscellaneous diva bill that's floating around.
Leslie.
I just can't imagine that we need to hear from every facility. We just heard someone representing all the hospitals who will then present data to us. We also have advocates that do that for long-term care facilities. I just don't see how establishing access is going to take all that long.
Person from the hospital said we don't need this.
Correct.
Right, but we're saying that
For the hospitals.
for the hospitals, but what about other facilities within our state?
That's why we need to hear from them.
That's right, but we don't need every one.
And
I'm just saying we have advocates that do that.
I think Representative Boslin sort of made the point of, yes, that's current practice now, but just having something in statute means it protects
Yeah.
it.
It's a guardrail.
Yes. And so it may be
Or
current
a belt
practice
and
now,
suspender or
but what
whatever.
happens in the instance where all of a sudden
It may be a finding. I mean, that all hospitals do it and that we want to, support that structure.
I can't see anywhere where prescriptions, pharmaceuticals, I can't see a place where this could possibly go.
Could it go into
This
diva
seems
bill?
more of a clinical thing, and I'm thinking we're not doing an awful lot around clinical.
I'm wondering if maybe like an ombudsman could testify as to what goes on at the nursing homes. Because I think it's, as I
We
recall.
would take more testimony.
Okay,
Obviously, if we turn it into a bill, we will take testimony. This was just an introduction
Mhm.
to the bill. So I'm asking, would the committee I'm asking to get a consensus from the committee, what your interest is in turning this into a standard form bill with guidance for legislative council on, you know, what we'd like to achieve with this. And if we would like to take this up. If nobody has interest in that, then we're not going to waste legislative council's time. I'm gonna go with Topper and then Brian.
Do you want to turn this into a committee bill?
Well, it would be a strike all. Right.
I'm interested in addressing the issue. What I'm not interested in is taking a massive amount of time on something that's unnecessary. Like if we spend the remaining 2 weeks before crossover, taking extensive testimony only to find out that we don't need to do this, it'd be frustrating when there's things that we need to do where the clock is ticking. And if we don't do it this year, like humanity may be in peril. You know, so not to be a dramatic, but I think you're gonna hear about the AI stuff later and then understand why.
I cannot imagine that with a limited scope that this bill would take very much time. I mean, I'm anticipating, okay, who do we need to hear from? We need to hear from long-term care, skilled nursing, anywhere where somebody is residing in a healthcare setting that would not have these specialty drugs on hand. I'm imagining that we would need to speak to, I don't know, the long-term care ombudsman. We would need to speak to, you know, maybe hear from the hospitals again, possibly board of, I don't know, who does prescriptions? Board of Pharmacy, thank you. And, you know, Board of Pharmacy, I'm not sure who else we would need to take extensive testimony on. And if we start taking testimony and it's like, wait, we don't need to do this, or we don't want to do this, then we just drop it. Alan.
I think we're making this too complicated. If you want to make it a bill, can't you make it a bill as it stands? And then we can work on that. And if you want to take a sentence out, we can.
That's what Jen.
So
was
if we're
just
all
explaining.
agreeing
Yeah.
that it's an important bill, we should just go along with it and then we'll do the.
We need to vote on whether or not we want this bill to be turned into a standard form bill.
That's the motion, so.
That's the motion. Go ahead.
Are we gonna take a vote on it?
Yes, I'm trying.
This is
to
a discussion, this is a discussion. Yeah, this is the discussion.
I'm ready to vote.
To actually. take
I'm ready to vote on it too. So
Okay.
I'm ready to vote on it.
And we just need a straw poll on this. All those in favor of turning this into a standard form bill? 1, 2, 3, 4, 5, 6, 7, 8, 9.
It's everyone present.
Yep. 0, 2. Okay.
Great.
So Jen, you need to write on what you would like
We're on the end of
us
the road.
to put in this bill.
Yes, I think, so Jen Kirby, legislative council, yes, right now it's sort of generally described.
Thank you.
But I think, yes, I'll need to know what healthcare facilities you want, and I think there were liability issues raised earlier that you'll want to address. Whose responsibility is to administer, to store, administer, et cetera. Those are the kinds of things that you will need to address.
Yeah.
And make sure that they are bills.
Go ahead.
So the what we approved includes the finding section. So
What you're doing is strike all, and anything you want.
yeah, so it proposes a finding section. So what I'm wondering is how would people feel about like a sentence or two stating our intent or purpose and a finding or two based on what we find, like saying like, according to, I'm just making this up as an example so people know what I'm talking, according to Voss, 100% of hospitals in 2026 have this policy in place. And finding number two, according to this organization, these facilities do this. And then purpose, it is the intent of General Assembly to guarantee that patients with rare diseases can have their medications in the facilities and don't go without care, or whatever, however we say it. And then Jen puts in the language that in statute that needs to be guaranteed, and that's it.
How about a legislative purpose intent of providing continuity of care across the healthcare continuum and findings of most inpatient or long-term care or residential settings do not have supplies of many specialty drugs.
Policy. But maybe we need them to establish a policy.
How about we have Jen draft?
Exactly. All I was saying is it should have a finding section and a purpose. That's all I was saying. I wasn't saying exactly what it should be.
No, I understand, but I'm just saying, we're asking for, okay, never mind, sorry.
Okay. Anything else?
I think I said, so liability, what facilities do you want? Is responsible for administering, dispensing, and storing the medications? And who bears liability if there is a problem?
In the phrase.
You want us to answer that
These are the
right
things
now?
that we do well, or
No,
these are
she
the
wants to
things-
know if we want those things in.
No, I think all of those things need to be.
That's what I'm hearing.
Yes.
That's what we need testimony about.
So do you need us to tell you right now?
No, she needs to know if they need to be in the bill. Then we will take testimony on them.
I think I'm telling you that those are the elements I would expect to put into the bill. And if there are others, I'm happy to do that. But I don't think we're prepared to tell me what you want in those categories. I think those are the issues that you may need to take testimony on.
Okay.
So that you can give me direction to draft a bill, but I don't believe I can draft a bill yet because it's still a concept.
Okay,
Jen, the phrase that's in here now, that's not good enough. Just saying,
What do you mean the phrase that's in?
inactivating for the medication adherence and continuity.
We can call it, I mean, you can keep the name if you like the name, but
Well, I'm
right
just
now
trying
it's
to figure out how we
description
can.
of what the bill would say if the bill were drafted, but it doesn't mean that I can then just go draft the bill,
we
I get what
will,
you're saying.
because the bill is very broad strokes.
we will schedule testimony for next week on this. And then we'll be able to give guidance to legislative council on what we did get drafted. Yes.
There should be wording that, like going to a hospital, taking your medication to a hospital needs to be in the original container.
Would also be part of your conversation.
The other thing is my mom lives in assisted living and she has to order her own medication, but they keep it and administer it to her. Or her doctor has to order it for her.
So you were saying like some areas that you would need more information on are
Which facilities?
which facilities, liability issues and dispensation
I'm
practice.
trying to think
Yeah.
from a practical standpoint, patient is in their bed in a room. How does the medication get to them? Who is responsible for preparing the dosage, administering it if it's a medication that needs to be administered? If this is something that would be taken home, I don't know the extent to which facilities allow somebody to, for example, administer an injection to themselves in a setting, in a healthcare setting, and whose equipment is used. So I just think these are some of the issues that would need to be addressed if you are going to require this. Or you could require, facilities to have policies, but it doesn't mean policy will do what you want policies.
May I comment?
Yes.
It seems like this is during transition, a transition period, because once someone's established in a place, their medications, and their medication lists are ordered and the facility can then order it and have it available. So I'm not particularly worried about the ongoing treatment of someone in a residential setting or in a hospital setting necessarily. Well, the hospital is transition. It's during these moments of transition, like for Anne's dad. So that's the sort of moment that I think we're thinking about in trying to protect patients. And that's sort of the idea, that patients in transitions from facility into a facility or whatever are protected or have access to their medication if it's not available.
Yes. I think that's what I'm trying to get at.
Yeah, but there's a brief moment.
Mhm.
It's not over time. Yeah.
Okay, next week, we will schedule a testimony. We're done for the morning. I was sort of hoping we might be able to move our afternoon up a little bit. Considering the weather, but I don't think that's gonna be possible. So I will see everybody back here at 1 o'clock, unless you have to leave. Or feel you need to leave, and you can certainly join on Zoom. So Tasha will send you the link. I will take the link. Okay. All right, if
I need a quorum, should we think about that for a sec? Because I'm not sure what I'm doing. I'm trying to figure it out. But who's definitely gonna be here for this afternoon?
Can't we count people on Zoom as a quorum?
I don't believe, does anyone know?
I don't think so.
If you can vote on Zoom, how could it not be counted as a quorum?
Yeah.
It's one of your three. I mean, that's a different question.
We could reschedule. We are scheduling testimony next, is it Tuesday or Wednesday on this? Is it Wednesday morning we had decided? Tuesday. We could reschedule this till that day. I was hoping that we could, the reason we scheduled it this afternoon is because we needed both Katie and Jen, and this was the time that both of them could be available. So, I mean, at least today, I'd like to get through the walkthroughs.
Can I check with the clerk and determine what the quorum would be? Because if the clerk says that we can have people remote and have it be quorum, maybe we can at least do what we can.
I'm looking at the rules, so give me a moment.
Who's leaving early?
I might be,
Valerie left. Yeah, Valerie.
and Lori's not here.
That's
Still,
4 people.
it's still a quorum.
We saw the quorum
Yeah.
start.
I'm not leaving.
I'll stay as long as I can. We may all, that means that if it starts snowing at 2, we should all leave because we're gonna be screwed. I have to work at the crisis service tonight, so I can't stay here.
I'm sorry, Katie was unable to get here until 1:30, right? Or was she available at 1? She's available. Do we want Jen to do? I'm just wondering if we could possibly move up our witnesses at 2:15, if they would be amenable to that. They're both on Zoom. It was, as early as they could possibly be here, 12:15.
Like, we could actually just work another hour and leave end early, is that what you're saying?
Yes, that's what I'm saying.
Yeah. I'd be down.
If we could possibly do that. If not, we could reschedule them till they could go before Katie, or we can try to get Katie in here with, Jen, I'm sorry, I don't know any sort of protocol around scheduling legislative council between 12 and 1. Do,
And, you know, we do whatever the committees need. We have, Jane and I have a meeting at 12:30, but
oh, okay.
if
Um,
you need us to schedule meetings.
I say we're gonna take a break.
How does the committee feel about it? Do you want to do this or not?
To,
I mean, that's,
I don't want to drive home in the snow.
I'm fine to stick around and stick with the schedule as planned.
I can stay around. No sweat. I'm not worried about that. But you got people that are,
Yes, yeah, I have a long ways to go.
so let's find out how many people can stay and we'll just do it.
Okay, 1, 2, 3.
I got, yeah. Anyone else can stay?
I'd like
I mean, I
to
can.
leave
I sort of
Okay,
can.
wait a minute, wait a minute.
Oh,
Wait,
it's no.
wait, shh, Deb's talking, 3:30. Okay, so you'll be here. Okay,
I didn't hear what time you said.
I'd like to
3:30.
leave by 3:30,
Oh.
but you guys are going into the
Yeah, yeah.
snowstorm. I'm running away from literally.
that's true.
So-
I've got close to 100 miles to go, but I'll stay.
Ooh,
I'm not gonna leave you short.
I think
I
you're
got a
running
truck.
away from it also.
I got a truck.
I think it's, am I correct, it's coming up from the south?
Yes.
It is, it's the Northeast commute is gonna have the least
Brian, what
impact.
time can you be here till?
I can be here in terms of work until 3.
Okay. Wendy, you're leaving?
No, I can stay.
The only issue is if it snows heavily, I won't get to work on time if I'm stranded on Interstate 89. So
Okay.
it is what it is. Like,
we've got to accommodate that.
Okay.
I can jump on.
We will keep testimony just as it is. At 1 o'clock, I will see everybody back here at 1 o'clock. Please be on time so we can get going and get moving. And if you have to leave and you feel you need to leave, then leave.
as it's going, yeah.
Yeah.
That's, we can
Or
do that.
before, it doesn't matter.
Here's the thing, I think that in terms of a quorum, I think that the quorum needs to be present when we open meeting.
We have a quorum.
And then as whatever happens, happens.
Right.
So we can start.
We have a quorum.
So I'll be here.
Okay.
And we can't